So thanks so much, Mike, and good morning, everyone. It's fantastic to be here. Firstly, can I express my thanks to Ali and the GlomCon team for the opportunity to present this data to you today, and not just for presenting it here in the room amongst the audience that I think is going to hear something special, but also for allowing it to be live streamed so people all around the world can hopefully join us and learn about the data that we're going to present to you. And I've been involved in a lot of clinical trials over many years, but I think the data you're about to see is some of the most important data that's been generated from any clinical trial that I've been involved in. So I'm going to introduce the topic, and then we're going to hear the results of the Visionary trial, the final results from the 2-year analysis of the Visionary trial presented for the first time here today. These are the disclosures for Dana and myself, and Visionary, of course, was funded by Otsuka. Oh, well, you can't see the disclosures in that case. Here we are. Okay, I could see them. So there are the disclosures. So let me just start off by providing a bit of background, much of which is probably not terribly necessary for the people in the room, but I think it's important we all start at the same place. So we've heard already this morning about the nature of IgA nephropathy, the fact that it's immune-mediated, that it's a progressive and, in most patients, lifelong disease. And it's a disease that we've underestimated over many decades to the detriment of our patients. We've called it a rare condition, but we've called it a rare condition because we've underdiagnosed it. We've reserved biopsy only for those patients at extremely high risk, and even in those patients, we've called it a slowly progressive condition. But we now know that the majority of people with high-risk IgA nephropathy will actually develop kidney failure within 10 or 15 years. And it's the boiling frog syndrome. When we're watching eGFR every few months, things don't change much from visit to visit, but when we look back over many years, actually our patients end up losing a lot of kidney function. And when they develop advanced kidney disease and kidney failure, of course, this has profound implications for that individual, usually people in their 30s and 40s who are now facing dialysis or transplantation, but also profound implications for their families, for their communities, and of course, for our society as a whole, given the costs of providing care for people once they've got advanced kidney disease related to IgA nephropathy. So there's an urgent need for us to have highly effective therapies that will change the trajectory of the future outcomes for these patients. The most recent IgA nephropathy guidelines produced by KDIGO have suggested twin treatment goals for us. The first being to reduce the kidney parameters to those of the normal population, and that means losing less than 1 ml per minute per year of eGFR and reducing proteinuria to less than 0.5 gram a day, or ideally less than 0.3 grams per day. And I'll get you to remember that 1 ml per minute per year number. It's going to be important when we see the data from Dana. And they've also suggested that we simultaneously manage the IgA nephropathy specific immunological drivers, which is the focus of the presentation today, along with the more generic CKD type responses, the maladaptive kidney factors that lead to progressive loss of kidney function in people with IgA nephropathy, and we won't focus on those today. So today we're going to talk about APRIL as a key driver in the 4-hit hypothesis of IgA nephropathy. And what we know about APRIL is it stimulates plasma cell proliferation and antibody class switching in B cells, both of which are critically important to the production of the abnormal pathogenic galactose-deficient IgA1 that occurs in people with IgA nephropathy, and the synthesis of autoantibodies against that galactose-deficient IgA1. Those two combine to form circulating immune complexes that deposit in the mesangium and cause kidney damage and eventually kidney failure. Sibeprenlimab is a humanized IgG2 monoclonal antibody that selectively blocks APRIL, and therefore, through its effects on B cells and plasma cells, leads to a reduction in the production of galactose-deficient IgA and matching autoantibodies that in turn leads to a reduction in the number of circulating immune complexes, and we anticipate a reduction in deposition of those immune complexes in the mesangium. But the big question that has not been answered to date is, does this result in long-term kidney benefit for patients? To answer that question, we designed the Visionary trial using a similar design to the one we've just heard about in this room. The trial included adults with biopsy-confirmed IgA nephropathy who had a UPCR of above 0.7 grams per gram or a urine protein excretion of greater than 1 gram per day. eGFR needed to be maintained at above 30 mils per minute, and they needed to have a stable or maximally tolerated dose of ACE or ARB, and they could have SGLT2 inhibitors if required or if suggested by the clinicians, as long as the dose of those agents had been stable for 3 months prior to randomization. Participants who met those inclusion criteria and who agreed to participate were then randomized 1-to-1 to receive Sibeprenlimab 400 milligrams subcutaneously every 4 weeks, or a matching placebo. And that was continued out to week 104, after which an additional 8 weeks of follow-up occurred. We randomized 510 patients in the main cohort that we're going to hear the data about today, and an additional 20 participants with an eGFR between 20 and 30 were randomized, and these will be reported at a future date. We've already previously reported the effects of the primary outcome in the trial, which was the urine protein creatinine ratio at 9 months. And we saw at 9 months in the placebo-treated patients, amongst the first 320 people who were randomized, stable urine protein level, 2.1% higher over those 9 months. And in Sibeprenlimab-treated patients, we saw a 50.2% reduction, previously reported, leading to a 9-month placebo-adjusted treatment difference of 51.2%, a highly statistically significant result, p-value of less than 0.0001. We saw this develop quite early on and continue out to 9 months, and we've already reported that this was sustained out to 12 months. So that meant that the primary hypothesis for that initial 9-month analysis was met, and we could move on to assess the long-term effects on eGFR. And that's what we're going to report to you today. This is a summary of the study design and the outcomes that we're going to look at, and the ones that are highlighted in orange are the ones that we're going to report today. So the first one is the primary endpoint at the interim analysis. I've just shown you the results of that. That was positive, which means we can move on and look at the key 2-year endpoint, which was annualized slope of eGFR estimated over 24 months from week 4. If that's positive, we can then move on to look at the next secondary endpoint, which is mean change in eGFR estimated from baseline at 24 months. And if that's positive, we can then move on to look at the time to first occurrence of a composite kidney outcome of kidney function decline or kidney failure. And then if that's positive, we can look at the proportion of patients experiencing at least one composite kidney outcome event through 24 months. The composite kidney outcome data will not be shown today. That's going to be presented at ASN later this year, but we're going to show you all of the eGFR data. In addition, we're going to look at the subgroup data for the stratification variables. And we also did a post-hoc sensitivity analysis that included the baseline eGFR level in the slope calculations. And we'll show you that result today, along with the safety data. These are the statistical approaches that were used. So for the key 2-year endpoint, a linear mixed effects model was used to model eGFR, starting from the first post-baseline visit through to week 104. For the secondary endpoint of change from baseline to 24 months, MMRM model was used. We've got summary statistics for the safety endpoints, and we did a post-hoc sensitivity analysis that included the week 0 data, and that was analysed in the same way as the key 2-year endpoint. I'm now going to hand over to Dr. Dana Rizk to take us through those results. Dana.
Okay, thank you, Vlado, for the introduction and reminder of the remarkable proteinuria data we've seen so far. So moving on to the final results, the 24 eGFR and safety results from the phase 3 trial. As Vlado mentioned, we ended up enrolling 510 patients, and shown here are the baseline demographic characteristics. The patient's age, on average, was about 41 to 43. They were balanced between the two arms on all characteristics. There was a slight male predominance of the cohort, as expected from the disease epidemiology. Very good representation across all races, with Asians representing about 60% of the cohort, followed by whites or Caucasians. This is a global trial with, again, a very nice geographic distribution, patients coming all the way from East Asia, about a third of them, South and Southeast Asia, Europe, North America, representing about 12 to 13% of the cohort, as well as South America. Patients were also well balanced between the two treatment arms in terms of their baseline clinical characteristics. So the time from qualifying biopsy to the randomization as a median was about 1.3 to 1.5 years. I would remind you that the requirement to get into the study was a biopsy-proven IgA nephropathy, so there was no limit on when the biopsy had to be done. But if patients had a GFR between 30 to 45, they had to have a biopsy within the last 3 years prior to enrollment. And if they had a C2 or T2 lesion on their biopsy, they were then excluded. The baseline UPCR, the mean UPCR in the Sibeprenlimab group was about 1.6 gram per gram based on 24-hour collection, 1.5 gram per gram in the placebo group, and you see the median values there, again, identical between the two arms. The baseline eGFR, the mean was about 65 milliliters per minute for the Sibe group and for 63.4 in the placebo group. Patients could have used immunosuppression prior to coming into the trial, of course, with the appropriate washout period, and the background of immunosuppression use included patients who had been treated previously with steroids. That number was fairly small, on the order of 3 to 5% of the population. Background therapy was, pretty high. RAS inhibition was taken by about 98% of the patients, and SGLT2 use was seen in about 45% of patients in both arms, again reflective of the change in the background or what we're considering standard of care, and you will see that throughout the clinical trials as they report their data. Most patients had a positive dipstick for hematuria, and hematuria here is defined as anything from trace and on. So again, we're going to start first by looking at the key 2-year endpoint. That's the annualized slope of eGFR estimated over 24 months from week 4. So as a quick reminder first is this goal that the KDIGO guideline put forth to try to reduce the GFR loss by less than 1 milliliter per minute per year for patients. Showing you first the placebo group, this is 4.2 milliliter per minute per year loss in the placebo group, compared to a remarkable stabilization of the GFR and a plus 0.3 milliliter per minute per year slope change. For a treatment difference that is highly statistically significant, but also highly clinically significant of remarkable 4.5 milliliter per minute per 1.73 meters squared per year. The initial analysis that was planned was to look at the annualized slope while patients were on treatment, so from week 4 to 24 months. So we did a post hoc sensitivity analysis to see if we included the baseline creatinine and GFR value, what would those analyses look like. So the sensitivity analysis essentially affirmed the same findings. This is again including the baseline value, and you can see that here again the placebo group lost 4.2 milliliter per minute per year, and the Sibeprenlimab group was stable and showed a plus 0.5 milliliter per minute per year for a slope difference of 4.7. reassuring that the data were pretty solid, regardless of how we looked at them. Now looking at the subgroup analysis, and again, these are pre-specified subgroup analyses. There were 3 that we looked at, the UPCR being over 2 grams per gram or less than or equal to 2 grams per gram at baseline at screening. The screening eGFR that was over 45 milliliters per minute or between 30 and 44. And the SGLT2 inhibitor use, yes or no, again, at screening. And as you can see, the results show, again, consistent results in favor of the Sibeprenlimab treatment compared to placebo, pretty remarkable and solid results. And you can see on your right-hand side, the different slope differences seen anywhere on the order of 3.7 to 5.9 milliliter per minute per year difference between the groups. Now let's look at the mean change of eGFR from baseline to week to 24 months or 2 years. We're going to start first by looking at the placebo group, and you've seen these curves over in other clinical trials. You see the tremendous loss of GFR in patients who are in the placebo arm. And at this trial, by the end of 24 months, patients had lost 7.9 milliliters per minute per 1.73 meters squared. On the other hand, in patients who received Sibeprenlimab, you see a flattening of that curve. And at the end of 24 months, patients had plus 1.3 milliliter per minute per 1.73 meters square, again showing a remarkable treatment difference of 9.2 milliliters per minute per 1.73 meters square at the end of 24 months. Importantly, let's look at safety. And the safety signal so far had been very reassuring. This is now looking at the entire cohort, the main cohort, so patients that were recruited in this part of the trial with GFR over 30 milliliter per minute at entry. You can see the safety was reported in any patient who received at least 1 dose of investigational product, be it placebo or Sibeprenlimab. And again, the safety data was very reassuring. There was equal distribution of treatment emergent adverse event that occurred during the treatment period, reported in about 90% of the cohort. Treatment-related adverse events were reported in about 30 to 35% of the cohort, again, equally distributed across both groups. Serious treatment emergent adverse events were numerically higher in the placebo group, and again, very well balanced between the two. And leading that group were infections and infestations, and I'll show you in the next slide more details about that. Serious treatment-related adverse events were fairly rare, on the order of about 1%, and equally distributed between the 2 arms. Severe treatment emergent adverse events occurring during the treatment period were also pretty low, 3.9% in the Sibe group and 7.6% of patients in the placebo group. Treatment emergent adverse events that led to discontinuation of Sibeprenlimab or placebo were quite low and higher in the placebo group, representing 4% of patients. And importantly, no deaths occurred during the trial. So digging a little bit deeper into the infections and infestations, and now limiting it to patients who had reported adverse events that were reported in at least 5% of patients or more in either trial group, you can see that most of the infection infestations, were upper respiratory tract infections, nasopharyngitis, influenza, and COVID-19, keeping in mind that when we started recruiting for the phase 3 trial, we were still dealing with the tail end of the COVID pandemic. Injection site erythema were reported equally in both arms on the order of 15% of patients. Injection site pain, injection site swelling, again, equally distributed between the 2 arms. And a few cases of diarrhea, fever, and peripheral edema. So in conclusion, Sibeprenlimab, a selective APRIL blocker, demonstrated stable eGFR over 24 months compared to placebo, and the placebo arm showed a continued decline in eGFR. The eGFR effects in the visionary trial are the largest reported to date for a phase 3 trial in IgA nephropathy, and meet the eGFR treatment goal that was proposed by the 2025 KDIGO guidelines for the IgA nephropathy patients. Again, that goal being less than 1 milliliter per minute per year loss. Sibeprenlimab showed consistent treatment effect across all the pre-specified stratification subgroups, indicating a broad therapeutic applicability in patients with IgA nephropathy. And at 24 months, safety remained favorable with similar rates of overall adverse events and infections between the two groups. Further analyses are ongoing for the 2-year results and will be presented at an upcoming scientific congress. I won't say which one. Thank you. And I want to make sure I thank all the patients, families, investigators, study site personnel, and site investigators. I know a lot of you are sitting here in the audience, and all the clinical and operational teams that made this trial possible. As Vlado mentioned in the previous session, pulling off global trials that enroll hundreds of patients is a massive task, and thank you again for everybody involved. So we'll open it up for questions. I'll come sit next to you so we can both answer. Richard, run.
All right. So thanks everybody who applauded. This is amazing data. Again, as part of the trial, I won't say anything more about that. But for the presenters, does this open up a new paradigm in IgA nephropathy, where if you take a population with a mean proteinuria of 1.5 grams per gram, 2 grams a day of proteinuria on average, reduce them to 1 gram per day, but see no progression on average? What does that say about our treatment goals for proteinuria? Are there mechanisms of actions where we can throw that out the window?
That's a great question, Richard. So yes, being able to stabilize an eGFR slope in this high-risk population is quite remarkable. And honestly, when the KDIGO guidelines came out, I don't know that I was a believer that we could achieve that. Your question about the residual proteinuria is a great one. I think we need, in my opinion, longer data to really see if we can ignore that residual proteinuria as long as the eGFR stays stable. Everything we know about proteinuria suggests that that's not the case. And so, time will tell from hopefully the open label extension and then again, some of the real world registries and data.
Just the only thing I'd add is, of course, what we're showing is the average, and there's going to be a lot of work to understand within that average the complexity of, are there still patients who continue to progress despite this therapy? I mean, what we see here looks a lot like cure, frankly, but it's 2 years, and is it everyone who benefits in the same way? We don't know yet. We're going to need to find that out.
It's really amazing to see, GFRs that increase. It's incredible. So I have kind of an academic question, I'm afraid, in response to that. Can you tell us about the thinking behind starting the analyses at 4 weeks instead of week 0? We saw that it didn't really matter, but just want to know your thinking there.
So I think this was one of the first trials that was done while we're still figuring out the methodology for doing these analyses. And in this model, the baseline eGFR was included as I'm not a statistician, but it wasn't included in the model because it was already included in the analysis in another way, and we didn't want to count it. But we did it both ways, just to make sure, and ultimately it made no difference, as you say.
Dana and Vlado, I think the term landmark is frequently used in the description of trials, but I must say this trial deserves the term landmark more than any trial that I've ever seen in IgA nephropathy. So congratulations.
Thank you.
The patients will be absolutely thrilled when this is published. and made public generally. I have just one question. It's a rather trivial one, but I think important. KDIGO guidelines in their recommendations emphasizes control of galactose-deficient IgA. Obviously, I have to ask the question, did this drug consistently reduce galactose-deficient IgA levels? And did you have sufficient data to analyze whether the degree of reduction in galactose-deficient IgA had anything to do with the GFR 24-hour?
That's a great question. We don't have the galactose-deficient IgA1 data fully analyzed yet, but it is in the works, so hopefully we'll have it. Stay tuned, I would say. From the phase 2 data, we do know that the drug does reduce galactose-deficient IgA1, and I'll show you some data in the next session about immune complexes as well, but absolutely. And then the other part of your question is an important one to look at whether the degree of galactose-deficient reduction, like galactose-deficient IgA1 reduction, correlate with, the response or the chance of responding. We don't know that either. Fernando.
Again, congratulations, and I echo Dr. Glassock's comment. This is a fantastic study. I'm just going to throw, because people who know me knows my views about IgA nephropathy. This is a glomerulonephritis. Glomerulonephritis, our landmark is because they have inflammation that is documented by proteinuria, blood, but hematuria also, which reflects inflammation in the kidney. And what you didn't show, but it showed before, is that this drug resulted in about 90% disappearance of the hematuria on these patients. So the point I would like to point to consideration is that in IgA, the KDIGO recommendations are based in flow evidence from the RADAR study that we don't have time to go over, but that's why they came from the less than 0.3. But what this study is showing, and I think is going to be shown by atacicept also, that is in IgA nephropathy, is the resolution of inflammation that is key. And if you resolve inflammation, the proteinuria, some degree of proteinuria, at least at 2 years, is not relevant. And this is just showing. So I think that the studies are proving what the logic is saying. Inflammation is the key. It's not just proteinuria. And if you resolve inflammation, you can deal with some proteinuria that remains.
So this is going to be an important thing for us to look at down the track. We will present what happens to hematuria at baseline over the course of the study in a future ASN conference. And we'll also present what happens in people who didn't have hematuria at baseline, which is going to be another important way of answering the sort of question that you're talking about. But watch this space.
Yeah, the music started, but go ahead. Oh, come on, give him the mic just 2 seconds.
Come and talk to us afterwards.
Yeah, okay. Sorry.
Thanks very much.
Thank you.